Chapter 14 goes over spinal cord and spinal nerves. So I know I had you watch chapter 16 first, just because the brain is so much more involved and really is the bulk of the central nervous system. Although the spinal cord does have some functional independence from the brain, it's more of just a kind of highway of axons that are ascending. So sensory axons that are going up towards the brain, or motor axons that are coming down away from the brain out to the periphery. There is some reflexive activities, and so that's the integrates and processes information independent of the brain. But what you find in the spinal cord is it's mainly reflexes. So the spinal cord, it really ends around L1. So I didn't have a very good color for that, but it really ends around L1 at what is referred to as the conus medullaris. It kind of tapers to a cone. And then after the conus medullaris, you have what is called the cauda equina, which is really just axons going efferent motor out or afferent sensory in. And so it kind of looks like a horse's tail. So cauda equina stands for horse's tail. And so once the spinal cord basically passes through the foramen magnum, we start having spinal nerves come off. And so you might notice that there are 8 cervical vertebrae, but there are only 8 cervical spinal nerves, 8 cervical spinal nerves, but only 7 cervical vertebra. That is because C1 comes out between, C1 spinal nerve comes out between C1 and the occipital bone. And then C8 comes out after cervical vertebra 7. Or below, I should say, below. So there are 8 cervical spinal nerves, but then after that, there's 12 thoracic spinal nerves. They're just named for the vertebra they come out below. And so they extend, spinal cord extends to about L1. There are what are called enlargements in the cervical area and in the lumbar area. And you might wonder why the spinal cord gets bigger in diameter. So an enlargement is bigger in diameter. And that is because you have arms and legs. So cervical enlargement is where your arms, the nerves for arms come out. And then lumbosacral would be where the nerves for legs come out. And so there's just more axons in that area. There's more nerves. You have nerves going out to the periphery. The filum terminal is really what tethers the spinal cord here to the coccyx. And it's also referred to as the coccygeal ligament. And when we look at the gross anatomy in the spinal cord, there's a few things to point out. So in the back, you have the posterior median sulcus. So sulcuses tend to be smaller indentations, whereas fissures, the anterior meaning fissure, tends to be, fissures are larger indentations. And again, remember, it's sensory in the motor in front, sensory in back. Same for brain and spinal cord. Therefore, what you're going to find on the anterior surface is going to be more motor, and the posterior is going to be more sensory. And that also goes for the roots. So the roots are going to be the axons. So dorsal roots are going to be the sensory axons, right, of afferent system. And the dorsal root ganglia are the cell bodies of the sensory neurons coming into spinal cord. So the ganglions, these are the cell bodies that are located just outside the central nervous system. They're pseudo-unipolar nerves or neurons, and then the dorsal root are going to be the continuation of the axons, the sensory afferent axons, and then they're going to synapse on a second sensory neuron that's going to go up to the central nervous system. Ventral roots are going to be motor. So ventral roots are things that are coming out, and dorsal roots are coming in. And so again, it's motor in the front, ventral, sensory in the back. So the ventral root is going to be motor. Motor axons. Spinal nerves, by the way, are going to be mixed nerves, right? Because spinal nerves have afferent, sensory, and efferent, motor axons. And so they're called mixed nerves. So going through this, and by the way, I want to point out that again, in these enlarged areas, you're going to have more gray matter because there's more cell bodies, increased number cell bodies and axons coming and going. So you have enlargement equals enlarged spinal cord. And so that's in the lumbar area as well. So the median surface has the anterior median fissure. Again, you ask yourself, is that sensory or motor? And hopefully you automatically say motor. Dorsal surface has the median sulcus. And again, ask yourself sensory or motor, and hopefully you say sensory. Dorsal root ganglia are the cell bodies of the sensory neurons. The dorsal root contains the axons of the sensory neurons. Ventral root contains the axons of the motor neurons. So somatic, again, is skeletal muscle, and visceral would be autonomic. And then spinal nerves are called mixed nerves. So those are basic things that I do expect you to know. And again, understand this concept, right? Sensory nerves are afferent nerves. They transport impulses from the periphery, from sensory receptors in the periphery to the central nervous system. Motor efferent nerves are going to carry impulses away to effectors. So effectors can be skeletal muscles, smooth or cardiac muscles, or glands. Enlargements. This goes through, again, increased amounts of gray matter or cell bodies of the neurons. In these segments of the spinal cord, because you have your arms and legs coming out. Goes through the coccygeal ligament, and then we get into meninges. So if for some reason you're watching chapter 14 before chapter 16, which is fine, I do go into more details about the meninges. There are 3 layers of the meninges. The outermost layer is going to be the dura mater. Then the arachnoid matter, and then finally pia matter is innermost. They're the exact same spinal meninges. They surround the spinal cord and spinal roots, as do surround the brain. And they provide the same functions, right? Protection, stabilization, shock absorption, and a way to deliver nutrients. The cell bodies only receive cerebral spinal fluid is what makes contact with the neurons. And so when we talk about that blood-brain barrier, not everything crosses over from the cerebral arterial blood flow into the cerebral spinal fluid. So some things do not cross and get pulled into the cerebral spinal fluid, and some things do. So that would be some medications or some things will affect your cerebral spinal fluid and others will not. The epidural space, by the way, is the space between the outermost dura mater of the meninges and the walls of the vertebral canal, or the walls of the cranium. So epi meaning on top of the dura mater, so epidural. When someone gets an epidural, they are putting the anesthesia on top of the dura mater, so it's not going into the meninges. It's there to anesthetize the spinal nerves coming out in that area, so you don't feel pain. Generally, in your legs or lower area. That's different than a spinal tap. So when you take a spinal tap, you're taking cerebral spinal fluid out to check for bacteria or viruses. Totally different process. I have written down where you get an epidural, take cerebral spinal fluid is generally below L3, preferably usually between L4, L5. And you say, why? Well, a lot of space. When someone hunches over and rounds forward, it really separates the vertebra and you have a lot of space to get a needle in there. And the second thing is there's no cell bodies of neurons below L1, so you don't worry about accidentally damaging a cell body of a neuron. So you go below L1 and you don't risk that. So spinal meninges, they surround the spinal cord and your brain, and even the spinal nerve roots as they come out. And so meningitis is can be bacterial meningitis or viral meningitis, but it's when the cerebral spinal fluid is infected. And so they will do a spinal tap, draw out some cerebral spinal fluid to check, right? To check to see if there's viruses or bacteria. And that is why people with meningitis, one of the symptoms of meningitis is a really, really, really bad headache, backache, neck ache, because there's an infection inside the meninges in the subarachnoid space below the arachnoid matter, and that's affecting and bringing a lot of inflammation to your brain or spinal cord. You also feel it in your nerves because even your optic nerves have meninges around right where the optic nerve comes off the brain, and so all those areas are very sensitive. Viral meningitis is self-limiting. Bacterial meningitis is the one that you get immunized for before you go live in the dorms or go live with a lot of people, because bacterial meningitis can quickly kill someone, whereas viral meningitis tends to be self-limiting and most people recover from it just with comfort care. But it goes through the dura mater, the outermost layer, and then stabilizes the spinal cord. Arachnoid matter has the cerebral spinal fluid in the subarachnoid space. And then you have the pia mater, which basically covers the brain, the outside of the brain and spinal cord. Looking at a sectional anatomy of the spinal cord, it's broken down into somatic and visceral for motor, right? Because, well, and we have sensory too, I shouldn't say just motor. Somatic is always going to refer to skeletal muscles, but if we're talking sensory, it could be receptors, general sensory receptors. And we'll talk more about receptors in chapter 18. If it's visceral, it's going to be autonomic nervous system or glands. And they can be sensory or motor. The cell bodies tend to be clustered. So somatic motor, of course, is going to be in the front because motor in the front. And then sensory coming in is going to be in the back. That's sensory. That's why it's ventral root or coming in, right? Afferent. So kind of looking at this and understanding, this is the dorsal root ganglia. So just kind of understanding these parts. Longitudinal landmarks, we kind of went through the anterior median fissure and posterior median sulcus. The gray matter, again, these are the cell bodies of neurons, and these are the axons, tracts, and columns of axons. So all this is axons. So this is the myelinated axons. Ascending tracts, they are afferent tracts. These are axons that are afferent sensory. And then you have axons coming down that are motor out, right? So those are the descending tracts. Organization of white matter, again, there are columns. Funiculi is the anatomical name for the columns, and you have posterior, anterior, and lateral columns. Columns are going to be either sensory ascending or motor descending. Gray matter, you do have the central canal where cerebral spinal fluid flows. And then you have these horns, these gray matter horns. They are, again, the cell bodies of the neurons. So if they're dorsal horns, they're going to be sensory. If they're ventral horns, they're going to be motor. There's also glial cells as well. White matter axons, myelinated or unmyelinated, most of them are myelinated, and they're organized in tracts and columns. We don't get into spinal tracts in this class. They are grouped, so you would have your pyramidal tracts or your dorsal meniscal tracts. There are different tracts that go to different specific things, and if you go further into functional anatomy, I believe they'll go more into spinal tracts. The nuclei, again, it's going to be ventral dorsal. Lateral tends to be visceral, so autonomic. Spinal nerves are kind of set up anatomically like muscles in the sense that you have a spinal nerve coming out, so it's showing you this right here, and there is an epineurium that covers, right, the outside of the nerve. So epi meaning around. And then you have bundles of axons called fascicles, are called fascicles, and they're surrounded by perineurium, right? So perineurium. And then inside the bundles of axons or these fascicles, you have axons, so individual axons, and they have an endoneurium surrounding them and a Schwann cell that myelinates them, generally speaking. These spinal nerves come out at the intervertebral foramen, that hole created by a superior and inferior articulating process of the vertebra, and the epineurium of the spinal cord becomes continuous with the dura mater, the meninges. So that epineurium and dura mater are connected. Ramuses, we don't get into rami, but these rami are basically where it can split off. And so you have a ventral ramus and a dorsal ramus, but off the spinal nerve, but we're not going to get into that level. So you guys don't really have to worry about that. 31 pairs of spinal nerves, and they're thoracic, or cervical, thoracic, lumbar, and sacral. There are plexes, meaning each spinal nerve comes out, so you can see each spinal nerve coming out, but then they rejoin again. And then after they rejoin, they become new spinal nerves, and then they could branch again. And so what you find is you get these like networks, and those networks are plexuses. And so you have cervical plexus. The most important nerve coming out of the cervical plexus is your diaphragm, and that really, the phrenic nerve is a combination of C3, C4, and C5 spinal nerves. So your body doesn't want to have to rely on just one nerve for something as important as breathing. And so you have 3 spinal nerves on each side, C3, C4, C5, that all eventually innervate the diaphragm. This is why your cervical area is so important. If you are injured, no one should be moving your neck or cervical area around, because if it's unstable, you don't want to kind of clamp off the phrenic nerve, because that will have someone stop breathing, and that would not be a good outcome. So you try to stabilize the cervical area to make sure it just stays in place, just in case, so your phrenic nerve is not disrupted in any way, shape, or form. Brachial plexus goes to the arm. And so you have several nerves that come out of the brachial plexus. You have the musculocutaneous, the median, ulnar, axillary, and radial nerves. They all go down your arm. Notice that there's C5, C6, C7, C8, and T1. They're mostly cervical spinal nerves. That's why if you sleep kind of awkward on your neck, or if your neck's turned really oddly when you're sleeping, sometimes your arm goes numb. Because your brachial plexus, the nerves that service your arm, are coming out of mostly that cervical area. Lumbar plexus, you have a couple of big leg nerves, the femoral and the lateral femoral cutaneous and the glenohumeral. Sacral plexus has the sciatic nerve. That's a big one that comes out of the sacral plexus. Now, each one of these spinal nerves, remember, they're mixed nerves. So it's sensory afferent axons coming in and motor efferent axons going out. But each one of these spinal nerves services a certain area of your skin called a dermatome. So a dermatome is, we know that cervical or nerve C7 is going to service your index finger here. And so if you're doing a nerve conduction study to see if C7 is actually working and healthy, you can have sensory to the skin in this area here. And if the person feels it, then C7 is okay, because if sensory is making it into your brain, then it's assumed motor is also doing okay. And so we can do sensory checks and do nerve conduction studies using these dermatomes to check every single spinal nerve coming out. We do have an overlap between some adjacent dermatomes, so that's why it's usually a specialist who conducts these to check after some kind of spinal function has been disrupted due to accident or disease or something. So these nerve plexuses, again, cervical, phrenic nerve, brachial, arm, lumbar, and sacral would be leg. And this just kind of gives you an idea about what a rat's nest it tends to look like. But what it does is, if you say accidentally clamp off C3, C4 is still going to connect to the phrenic nerve, and C5 is going to connect to the phrenic nerve. And so, you know, you're going to end up able to keep breathing. So it's important, these plexes. If you go farther into medicine or functional anatomy, you learn the different roots. So remember, we talked about roots coming out. So here's the ventral roots. So these are motor. And so you have C5, 6, 7, 8, and T1 roots coming out here. But each one of these roots then merges again into what is called a trunk. So you have 3 trunks. You have a superior, middle, and inferior trunk. And then the trunks are going to branch into divisions. And so do you see how they're now kind of intermixing? So each one of these C5 through T1 are sharing information, sharing axons, And by the time you get to the cords, they're all back re-merging into 3 cords. Then they branch off and they split into the actual nerves. So you're going to end up with radial nerve, ulnar nerve, median nerve, musculocutaneous nerve. And so then those are the ones, the main ones that go down your arm. The kind of way I learned it in medical school was really tired, drink coffee, going this way. So roots, trunks, divisions, cords lead to nerves. Really tired, drink coffee. So the brachial plexus, these are the main nerves that go down your arm. Most of you guys know that the ulnar nerve is servicing the pinky. You know, when here's that medial epicondyle and how the ulnar nerve goes right past there and it goes to this area. So if you hit that, you really feel it in your pinky. Radial nerve tends to be most of the palm of your hand. And then the median nerve, I should say the back of your hand, sorry, for radial, and median nerve is the palm. Lumbar plexus and sacral plexus, you have the big sciatic nerve, goes down the back of your leg, which is really most of these spinal nerves coming out in the sacral plexus, lumbar plexus, big femoral nerve coming out, obturator nerve. So these go down your leg. And it kind of shows you the areas. I'm not really asking any specifics on spinal nerves, but it's important to go over this stuff. I do want you guys to know the definition of a reflex. When it comes to the spinal cord, or even cranial reflexes with your cranial nerves, the definition of a reflex is an immediate voluntary motor response to a specific stimulus, meaning a specific stimulus is going to cause a specific response with little to no variability every time. And so it doesn't have to, I have this because this is really your cerebellum and your cerebrum, right? Your motor cortex is all up here, but a reflex is not going to even go up to that level. It's a sensory input that goes through the level of the spinal cord out to an effector. Never, ever cross, going up. You will have an axon from this reflex that will go up to let you know, but it's generally after that happens. And so an example of a reflex arc is you have a stimulus. So in this case, it's putting your hand down on a sharp object, right? Whoops, you did not need to see that. And so a receptor lights up, activates a sensory afferent neuron going in, and it's a monosynaptic. Basically, it's going to synapse on a motor efferent neuron, which is going to go out and make your bicep contract, flex, and lift your hand. It also splits in this interneuron synapse to relay to your brain what's going on. So if you need to make an adjustment, say if it was a foot and you have to lift this foot, you have to extend the other foot to make sure that that foot's going to be on the ground. But a reflex arc is a stimulus, activation of a sensory neuron, information processing in the central nervous system, which activates a motor neuron, which then affects an effector, a response in an effector, and that is what a reflex arc is. Reflexes, by the way, you're born with certain reflexes, right? So those are innate reflexes, genetically determined, you're born with it. Then there's acquired reflexes. These are the ones you learn. For instance, if you see a ball coming at your face, you're going to automatically duck. You don't have to really think about it. It's going to be reflexive. I should say after the first time that ball hits you in the face, it becomes reflexive, because once you have something happen to you, for example, brake lights in the car in front of you coming on, you're automatically going to put your brakes on. It's an acquired reflex. You don't have to debate it. You don't have to think about it. It doesn't have to go to your prefrontal cortex. You just do it. So learned reflexes can be anything from some kind of sports activity to playing guitar or music. There's all kinds of acquired reflexes. It doesn't have to just be like driving your car flinching. We do a lot of things that we do it so many times it becomes an acquired reflex. Somatic reflexes, somatic again refers to skeletal muscles, right? So stretch reflexes, patellar reflexes, whereas visceral reflexes, that's going to be like vomiting or sweating when you're nervous, or smelling something that smells really good and you're hungry, you automatically start secreting saliva. Those are visceral reflexes. It's not like you have a choice. It's a reflex, right? So you have a stimulus, which is the smell, and then if you visually see it, that's going to cause a gland, your salivary glands, to start secreting saliva. Or if it's something super gross and smells really bad, it can trigger a visceral reflex like vomiting. These reflexes can be very simple, like a stretch reflex, which has one synapse, or it can have many, many synapses, which is polysynaptic. And reflexes can either involve the spinal nerves or the cranial nerves, so cranial or spinal reflexes. So classification of reflexes, just again, mono or polysynaptic, depending on how many synapses. Monosynaptic, like the stretch reflex, you have these receptors called muscle spindles embedded in your skeletal muscles, and they're sensing the length of your muscle. And so if your muscle starts to get longer, these muscle spindles are sensory afferent receptors, and they send a sensory signal in to then have a motor command then activate to shorten your muscle back to the original length, which is the contracting of a muscle. An example of this, you start to fall asleep. So like right now, you could be so bored that your head starts to go down and you start to fall asleep, and your neck muscles get a little bit longer. And those muscle spindles then sense that your neck muscles are getting longer, and they send a sensory activated neuron a message into your spinal cord. We better shorten up that trapezius muscle before it extends too far or lengthens too much. And so it will activate your trapezius to then extend your head back, which is the contraction of the muscle. The patellar reflex, you have these receptors also in your tendon that sense tendon length, right? So that's tendon. And when you hit this with a hammer, what happens is you're actually making it longer, right? So you hit it with a hammer and you make that tendon a little bit longer, which then activates the receptor to say, hey, we need to shorten up our muscle. So it contracts the quadriceps at the same time it inhibits the hamstring muscles. And so your quads contract and kind of move your leg out a little bit because that quadriceps do extension. So that's why you have a little kick in the foot. We can override some of these. So if you're focused on not letting your foot come out, whether consciously or unconsciously, you don't get a huge reaction. A lot of times if you feel like someone is kind of trying to control a patellar reflex when you're testing it with the reflex hammer, you distract them, have them count, have them close their eyes and count. And when they're distracted, their brain's distracted, you get a much bigger sensory reflex out of their patella. Cross-extensor reflex, this is polysynaptic. This happens in your arms and legs. When you have to flex one side due to a stimulus, so this stimulus is someone grabbing your arm, you're automatically going to flex the arm that someone grabs. And that's going to cause, along with flexion, an extension of the opposite arm or leg. So that's reciprocal activation. This happens in your legs too. So think about it. If you step on something, if you're walking and your left foot steps on a sharp nail, you're going to flex your left foot and extend your right foot so you don't fall on the ground, right? You need to have one foot come down to brace your body. So this is the cross extensor. That's all I have for you for chapter 14. And we'll finish up the nervous system with chapter 16.